the third in the series of webinars that are sponsored by the Saudi Society of Blood and Marrow Transplantation, SSBMT. The series of webinars is called AI in Healthcare webinar series. We've kicked off this series with an online workshop of how to utilize AI as a healthcare provider, and now we moved to the theme of impact of AI on hematology in general, so malignancies, clinical trial conduction, and so forth. I'm co-hosting this series with Dr. Aziz Nazha, who I'm going to hand the microphone just shortly. But I would also like to thank the sponsor of tonight's event, which is Cracking Multiple Myeloma. Johnson & Johnson, Janssen Arm, has always been a great supporter for educational activities in Saudi Arabia. And we would like to extend our thanks and appreciation for sponsoring tonight's meeting. So Aziz, I'm handing the microphone to you to introduce the theme of the subject tonight.
Thank you very much, Ahmed, and welcome everyone. It's a great pleasure to be with all of you today. And this series, I would say, it's been amazing. Now it's I would say the fourth time we meet, and we have a great attendance so far. And the idea behind the series is really try to bring AI education through the Society of Bone Marrow Transplant. In the way we have been doing it, choosing a topic that is important in hematology. We have an expert who comes and talk about, let's say, a disease. In today's session, we have Dr. Majed Al-Ahmadi, who is going to be talking about the prognostications of multiple myeloma. Then it's going to be followed by an expert on AI, and then try to apply AI to diagnosis and monitoring and resistance of disease. And this, I think, has been very successful in terms of trying to lay the land of where the clinical and research opportunities in certain disease, and then how AI could be applied in this setting. So I'm really excited about today, and I look forward to great conversations, and I hope all of you join us at the end sort of the presentation, ask questions, making it more conversational with our speakers. So without further ado, I'd like to introduce Majed, go back to Ahmed to introduce Majed Al-Ahmadi for the first talk.
Thank you, Aziz. Again, it's my pleasure to introduce my friend, Dr. Majed Al-Ahmadi. We both work at Princess Noor Oncology Center in King Abdulaziz Medical City, part of the National Guard Health Affairs in Jeddah, Saudi Arabia. Dr. Majed Al-Ahmadi, he has subspecialization in lymphoma and myeloma disorders, plasma cell dyscrasias, and he has vast experience in myeloma, as well as he leads our myeloma lymphoma fellowship. He's given many previous outstanding talks about myeloma, and I could not have found any better person to kick off the meeting of tonight. In the next 20-25 minutes, he will talk to us about the current status of prognostication in multiple myeloma. So, Majed, the microphone is yours.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. السلام عليكم and good evening everyone. So at the beginning I want to thank SSBMT for the invitation, and for Dr. Absi and Dr. Aziz for organizing these very important webinars, which I think will have it's an important topic. Either we like it or not, AI will have a huge impact on the health system in the next near few years, I would say. It's funny that how things are progressing. I remember in the last few years, when patient comes to you, they will tell you we Google it. Now people will say we chat GB it. So it's important, and it's very interesting how things are going quickly. I've been asked to, to present the current standard of risk stratification in multiple myeloma. A very important topic that there are lots of unmet need in it. So I'll start my presentation with one of my patients that I have looked after. So she's a 60-year-old, very pleasant lady. She came to our center with bone pain, with the imaging showed multiple lytic lesions. She was anemic, but normal calcium and creatinine. Her SBIB M protein was 65 grams per liter. IgG kappa on immunofixation, kappa to lambda ratio were 8. Bone marrow showed a 45% kappa restricted plasma cells, and her FISH cytogenetics came back normal. Important to mention that plasma cell sorting was done on that biopsy, on that sample, I mean. Her beta 2 microglobulin were 3.3 with albumin of 38, normal LDH. She's healthy otherwise with a good functional status. So based on the current prognostic index, so she's ICE stage 1, no high-risk cytogenetics, normal LDH. So by definition, she is a standard risk, new diagnosed multiple myeloma. So she was treated with our, known induction at that time, 4 cycles of VRD. She achieved a VGPR after induction, and then she underwent a stem cell transplant with melphalan 200 consolidation with 2 VRD, achieved stringent CR. She was started on the known maintenance for that time, which is lenalidomide single agent. So less than 2 years post-transplant, she came with febrile neutropenia, low hemoglobin, and she was neutropenic. Her light chain, she had a light chain escape disease with kappa of more than 1,000, a ratio of 230. Bone marrow done showed almost the whole bone marrow was replaced by plasma cells of more than 70%. And she had a new clone or clonal evolution with FISH cytogenetics showing 17% in more than 20% of the cells. So she was salvaged quickly with DARA carfilzomib dex. So she is a DARA naive because she did not expose to DARA as part of her upfront therapy. So she received 2 cycles. Most of it was inpatient because of need for blood product transfusion and severe thrombocytopenia. But despite that, no response at all. She was still cytopenic. She was ill. We tried also with pomalidomide-based therapy for her, and also there was no much of a response. At that time, no bispecifics or CAR T-cell therapy were available in our center. So she was referred to my clinic at USA, and she underwent for consideration of CAR T-cell. So while waiting, she received POM cyclodex, achieved almost a PR, and transfusion requirement has improved a bit. She was transferred to USA Mayo Clinic, underwent T-cell apheresis, and there she received the DARA KPD as a bridging till T-cell manufacturers. It took about 7 weeks till she get the infusion. So she infused with cell-to-cell that was associated with CRS of grade 2, no ICANS, febrile neutropenia, with neutropenic sepsis that required a short ICU stay, prolonged neutropenia. On day 30, bone marrow post cell-to-cell showed MRD negativity, as well as day 30. She was transferred back to us around day 100. Bone marrow was negative by flow cytometry. We don't have, it's not powered for detection of MRD. But by SBIB and free light chains, she was in stringent CR. She continued to be neutropenic and thrombocytopenic, requiring growth factors. And also she was hypogammaglobulinemic, receiving monthly IVIG. Currently, she is almost 2 years post cell-to-cell infusion. She's still in stringent CR, and her count has improved much in comparison to what was before, and her functional status also has improved significantly. So if we look at this case, this is an example of the unmet need we have in terms of risk stratification in myeloma. So I presented to you her initial presentation with, and if we apply what we know now in terms of prognostic modules, she will be labeled as a low risk. And we know that these patients who have, who has a low risk disease, with induction and single transplant, their median PFS around 4 years or even more. But this poor lady, she progressed within 2 years with a clonal evolution of 17p. So all of these, we don't have that predictive module to tell us exactly which one of these low-risk patients they do poorly than others. So, and that's the importance of the talk that we will have today, and that's why we are meeting here, so we can dig more into the details of this, how we can risk stratify patients of newly diagnosed or even in relapse refractory in a better way, using AI as a way to help us to do that. So when we are talking about myeloma, we face actually multiple challenges. The first thing, which I think the most important one, that it's an incurable disease. So regardless what you do, you will eventually, the patient will relapse. And it's always hurt when the patient asks you this question, am I cured? And unfortunately, the answer is always, unfortunately, no, because regardless how long the remission, most of these patients, they relapse eventually. And the disease has important, effect on their healthy life with, bone disease, renal impairment, and all of that, which will affect their quality of life with bone pain and so many other complications. Also, it makes things even more challenging that this disease affects more elderly. And despite all of the improvement we have in risk stratification, still risk stratification is not clearly defined. And what's more importantly, it's treatment is not risk adaptive. And I'm going to explain that during my talk. Also, an important thing to mention that the availability of drugs are quite limited. It's different from one country to another, different from one region to another. And the financial impact of these medications on the health system is quite huge. So someone might ask, can we use the risk stratification in defining which patient can benefit from that very expensive drug rather than the other patients? So all of these questions that we really want to define. So I'm going to talk about risk stratification in myeloma, and as well as MRD assessment, as was asked, requested from me during this talk. So when we are, talking about the risk factors, some of them are related to the patients, and that's important. And unfortunately, that was not incorporated in most of the prognostic modules. Age, the older the patient, they do worse because they will not be eligible for transplant. They might not be eligible for other treatment modalities, and also elderly people, they come with their own comorbidities and with their own home medications with many interactions. Also, the disease or the malignant clone. And if we want to see the progression in the risk stratification, so in this cartoon, you can see that how things were progressed from ISS to RISS to R to ISS. So meaning that the understanding of myeloma has improved over the last 2 decades, but still way more to go. Now, incorporation of the cytogenetic abnormalities, LDH, and other biochemical markers.
Ahmad, did
Dr. Majid, can you hear us? We cannot hear you anymore. I think your screen is frozen. If we can disconnect Dr. Majid and reconnect him again, or
Hello?
okay, here we go. Yeah, we can hear you now.
I'm not sure at what point I was lost here. So
I think a slide before this one, if you can go back. Yeah, here. That's the slide.
oh, this one. I'm sorry about that. I'm not sure what was the problem. So this is just to show that how the understanding of myeloma has evolved over the last 2 decades, moving from ISS to RISS to R2ISS, incorporating more variables, biochemical, and also cytogenetic abnormalities, meaning that now, luckily, we know better about the risk stratification in myeloma, but still way more to go. Also, the morphology of the bone marrow, so the plasma blastoid morphology associated with worse outcomes, presence or absence of amyloidosis will have an impact. Also, some immunophenotypic markers like CD45, 56, which increases the risk of plasma cell leukemia transformation, and also the proliferative index, the BCLI, same to what's happening in lymphoma, for example. The more aggressive lymphoma has more proliferative index. The same thing applied for myeloma. So the cytogenetic abnormalities has the important role in prognostication of myeloma. So multiple cytogenetic abnormalities. The most widely common one is trisomies or hyperdiploides, but that has actually a better prognosis in comparison to others. So if we want to think about what are the high-risk genetic abnormalities, 17p would be definitely the top one. After that,
He's frozen again. Can we try to do the same thing if we can reconnect with him?
like maybe his internet connection is weak.
Yeah, Dr. Majid, I think we missed some of your slides. Can you hear us?
I think I have a problem with the connection. I don't know why.
Yeah, now we can hear you. So if you can go back to your last slide you were on.
I'll try to connect with a different way. Sorry. Can you see my slide now?
Yes. Yes, we can. But if you can start the presentation, yeah, here you go.
Okay. So these, I'm not sure if you've seen this slide. So these are the most important cytogenetic abnormalities that will affect the patient prognosis. 17p and deletion 1p had the worst outcomes in terms of prognosis. After that, translocation 414, 1q amplification, and 1114 to lesser extent. So there are multiple prognostic modules used in the prognosis of multiple myeloma. The M-SMART one is one of the commonly used one, especially when in USA. So it defined high-risk patients based on cytogenetic abnormalities. So they bundled all of these together. They did not differentiate which one is worse than the other. So translocation 414, 1416, 1420, ISS stage 3, all of that bundled together as high risk. But if the patient has two cytogenetic abnormalities, will be eligible for double hit myeloma as diagnosis. If there are three abnormalities, then will be called as a triple hit lymphoma myeloma, which has worse outcomes. The IMWG module based on ISS staging, LDH, and presence or absence of 17p, 1q, and translocation 414. Based on that, the patient will be labeled either as a low risk, standard risk, or high risk, with difference in overall survival based on that. The IFM module also used three different variables: high LDH, ISS stage 3, and adverse cytogenetics, including 414 and 17p. What's more important to be mentioned is the more updated guidelines from the IMWG and International Myeloma Society, which defined now the high risk. So they looked at multiple variables, and they excluded most of the variables because with the current treatment practice, these variables did not affect the prognosis as much as these ones. So now the definition of high-risk myeloma is basically 17p deletion in more than 20% of the plasma cells, TP53 mutation, biallelic 17p deletion. So any one of these, immediately the patient will be high risk. Then combination of 114 abnormalities and 1p abnormalities. So either 414, 1416, 1420, along with either 1q amplification or 1p deletion, or having the two chromosome 1 abnormalities, 1p and 1q amplification together. So the IFM, they looked at all of their patient pool of myeloma, which include thousands of patients, and they found that in terms of prognostic significance, 17p has the most important prognostic impact. So patients with 17p, the EFS is as low as 15 months in comparison to the non-p deleted patients. So an important message, an important question that we always ask ourselves, where to draw the line, because 17p is not uncommon in myeloma patients. If you look at the clinical trial, the definition of 17p is quite heterogeneous. Some clinical trial will call the patient 17p even if the percentage of the positive cells is as low as 1%. Some as the IFM, most of the IFM trials, they require a positivity of up to or more to 60% of the cells as a cancer clonal fraction. So the IMWG and the IMS looked at a huge data set, and what they found that the line should be drawn at level of 20%. So if the patient has a 17p that's less than 20%, their prognosis is not very different from the non-17p deleted. But once the percentage of the myeloma cells that has 17p deleted reaching 20% or more, the prognosis get get worsen dramatically. And the higher the percentage, the higher, the worse the outcome. So once you reach a level of 40, 50%, prognosis becomes very dismal. Another important point is the double hit or triple hit myeloma, which combination of biallelic TP53 amplification of 1q to 4 copies plus ISH stage 3. And putting all of these variables together, so patient who has all the three variables, they do very poorly, as you can see here in the brown line here. But 17p, is it only the TP53? So the answer is no, because in about 60% of the patient who has 17p deletion by FISH, if you run a PCR, the TP53 is intact, meaning that 17p deletion does not just reflect the TP53 status. There are more other into the definition of 17p. So translocation 14, 16, and 14, 20 is not uncommon. Is actually not common in myeloma patients, but it's usually associated with other cytogenetic abnormalities that affect the patient prognosis as 17p or 1q. And you can see here from the analysis, if the 14, 16 or 14, 20 are alone, the prognosis of the patient does not get affected much. But once it's combined with other abnormalities, especially the 1p or 1q, which is a common partner with them, the prognosis go badly, as you can see here with the red line. The same thing applicable for translocation 414. In most of the prognostic modules, 414 was considered as a poor marker, but now looking at the data we have now, only 30% or 40% of these patients with 414, they do very poorly. The other, the 60% or the 70% of translocation 414, they do as good as the non-translocated patients. And that most likely related also to the same finding that usually 414 associated with other bad cytogenetic abnormalities like 1q and 1p. So always look at the partner. And we can see for the 414 alone, usually their outcomes are not as bad as the one with 414 plus one chromosome 1 abnormalities. How that will affect the treatment decision. So we know from this analysis done a while ago that patients with 414, they respond well to the proteasome inhibitors. Chromosome 1 abnormalities, also either 1p or 1q, associated with very bad outcomes. Biallelic 1p, they do as poorly as 17p, and also combination of both 1p and 1q amplification associated with very poor outcomes. With regard to the beta-2 microglobulin and how that affecting the prognosis, it's correlating with presence or absence of renal failure. So if you have a patient with renal abnormality and their beta-2 microglobulin is elevated, that does not affect their prognosis as someone who has a normal kidney functions, but the beta-2 microglobulin is high. So points that are not included in the current prognostic algorithm: extramedullary disease, circulating plasma cells, and plastoid morphology on the patient biopsy, along with the clinical features as age and comorbidities. So if we look at the current practice guidelines, unfortunately, it's not tailored based on the patient risk. So the main question is the patient transplant eligible or transplant not eligible? And then everyone is treating the same, which is, a bit frustrating, because we know that these patients, they don't respond in the same way. And, the treatment decisions must be also well defined. So as a conclusion and unmet need, so benefit risk stratification needed for the current era, including all clinical, biochemical, and genetic factors. These prognostic modules should be easy to apply with more available testing, and that should be applied on a risk adaptive approach. So when it comes to the MRD in myeloma, so I will not take much of time here. So it's well known now that a deeper response in myeloma, meaning a better outcomes, and that was clearly defined in the IFM 2009 trial, where patient who achieved MRD negativity has a much better PFS in comparison to the patients who did not achieve MRD negativity, regardless to which treatment arm. This table actually summarizes multiple clinical trials that looked at the same finding and all tell us one important point, that MRD negativity is the most important prognostic markers for patients who receive treatment, and it's a very good predictor on the patient performance in terms of PFS and overall survival. Based on that, the IMWG came with their guidelines almost now 10 years ago, defining how can we define MRD negativity, either by flow, by molecular, or by imaging. So important points to mention here, that the flow much be done by multicolor Euroflow, and the limit of detection should be 10 to the power minus 5. The same thing with NGS. You should be using the lymphocyte platform with the limit of detection of 10 to the power minus 5. MRD by imaging done by PET-CT, and the patient must have a baseline PET prior to therapy, and you compare it with the PET post-treatment. And it's not similar to what's in lymphoma. So in lymphoma, we call CMR at Duvel 3. Here, no, it must be below the SUV max of the mediastinum, meaning it must be less than or equal to Duvel 2. So how can we modify our treatment strategy based on that? Multiple trials looked into that. The first one was the MASTER trial, and you can see here it's an MRD adaptive approach, which showed that using that module it's very interesting, very interesting idea, and we can see that patient, more than 3/4 of the patient achieved MRD negativity post consolidation. The same thing applied for the more recently presented Persuas. So for the patient who were randomized to receive Dara VRD as an induction consolidation, they were randomized again to based on, I should say it was a MRD adaptive approach for the maintenance. So after 2 years, if the patient is MRD negative, they will discontinue the Dara and continue with Lin only. If they are MRD positive, they will continue on both. So we don't have the data for that yet, but that would be interesting thing to observe. And it's actually this trial and the other trials I'm going to show you, it actually showed the point that achieving MRD negativity associated with the better BFS for that group of patients. The same finding was with the HMG HD7 using ESA VRD versus RVD. Their primary endpoint was MRD negativity, and that's an important point now in most of the new clinical trial, because with the quadruplet, it's gonna take a long time to see a PFS difference. So using MRD would be a good surrogate marker for long PFS. So the same finding, MRD negativity was better in the ESA VRD, associated with a better PFS, as was documented with this trial. The same was applied for the ISA-KIA trial, the same approach. So induction, transplant, consolidation with MRD detection along the road, and the same finding, patients who achieved MRD negativity, they had a better outcome. So as in conclusions, MRD, sustained MRD has associated with better outcomes. It became an important measure at end of an endpoint in many recent clinical trial, forecasting a better PFS and overall survival. Unmet need that we need, and hopefully that will be explored in some ongoing clinical trial. Wider availability of MRD testing, more unified techniques of NGS, of MRD detection, either by NGS or NGF, MRD-based adaptive approach. Still, that's not unified in clinical practice. Hopefully, we will have a better answer with some ongoing clinical trial looking into that. That's what I have for you. Thank you so much. And sorry for the technical issues that happened.
No worries, Dr. Majid. Thank you very much, Aziz.
Thank you,
Excellent job,
Majid.
Dr. Majid.
That was amazing. That's excellent. It's been a while that I didn't hear anything about myeloma. So that was a great summary of all the prognostic models in multiple myeloma. And that's a great segue to the next talk with my great friend, Torsten Haferlach. It's really great pleasure to have Torsten with us today, because Torsten has an interesting story. So he started as a physician and a leukemia doctor in Munich. And then with the all revolution of genomics and omics that was in 2000s, he decided he wants to get out of in academia and build his own lab with two other partners. And that was in 2005. And that was the birth of Munich Leukemia Laboratory. And what's remarkable about this is the journey from 2005 to 2025, and fast forward 20 years now, the lab is probably, in my opinion, the most advanced lab for leukemia around the world. The lab handles, I think, around 140,000 samples from around the world. The lab is open 7 days a week. And Torsten continued to be involved in academia, and the lab involved in academia. We collaborated a lot on great projects, and the lab and the team has published hundreds of papers on diagnosis of leukemia and lymphoma. And what's also impressive is I think it's one of the probably early labs to adopt AI and integrate AI in the lab and automate tasks with AI and drive benefit with AI beyond just the research, so it has a clinical application. So I'm really excited to have Torsten to share with us how does he think about AI, how this technology is applied in his lab, and the amount of success that he has in his lab. So Torsten, welcome to the meeting today.
Aziz, thank you very much for this very, very, very kind introduction. It will be hard for me to give a talk according to this. Can I try to share my slides, please? Dr. Al-Ahmadi, can you give me the right to share my slides, please, or anyone else? Here we are. Fine, thank you. Okay, thank you very much. And you, Aziz, you're right. I'm still treating patients. I'm still a hematologist, and this is good for me to see what's going on with all these options of diagnosis and more personalized treatment. And I very much would like to thank Dr. Al-Ahmadi giving his great talk before me. There will be few overlaps, but these overlaps are not so hard to follow because we are going into the same direction and moving a little bit forward. And what I will do, as Aziz just pointed out already in his introduction, I will try to connect everything that was said before. What is missing? What are the unmet needs? What do we do in routine? What does the patient wants to know, and what do we want to know the next day to treat the patient even better? I would like to connect this with our workflows, with our approaches, especially using already AI in daily routine. And as you heard before, I'm one of the part owners and founders of the MLL. So I don't need to tell you this again. However, and this was also a subject of the other talk, I really need to point out also in this talk, as I did this 1,000 times in AML, for example, I don't like any percentages that make differences in prognostic scoring systems. Why should the patient with 59% of plasma cells be different to those who has 61% of plasma cells? I read bone marrow smears now since 40 years, and I can tell you it's stupid to believe that these thresholds mean anything. I completely agree that 20% and 100% is a difference. But all these things that we need to apply is based on biology, and it's based on those people who measure and who read these bone marrows. And the same is even more true for application of fish. And we heard, and this is true, and I completely believe that all these fish aberrations are very, very important. But we will come to this back later. And what we all would like to understand better, including AI for sure, up from today, and including MRD in not hopefully some clinical trials, but in every aspect we treat those patients, because many patients are treated without any clinical trial, and this will be true in the future as well. We want to know who should we treat, when, with what, and how long. Because if a myeloma has this shift to a higher degree, as we heard from the first patient, Dr. Al-Ahmadi showed us, from normal or good cytogenetic aberrations to 17p aberrations, that's a bad time point to think about it. And all these staging systems you see here, they use plasma cell fish. Some use already gene expression profiling. We heard about that also before. But this is rare. For example, for good reasons, we do not offer these assays in routine for gene expression profiling to define the prognostic information in the multiple myeloma patients, because the staging systems that are applied in routine worldwide at least ask for fish on plasma cells of the bone marrow, and then for MRD hopefully in the future. And you heard all this as well, but I can tell you, if you run fish for multiple myeloma in bone marrows, you need purified plasma cells. I will show in 2 or 3 slides how that works. And we do this 6,500 times a year. We never apply fish on routine bone marrow smears. We, in all cases, purify these plasma cells. Not only for fish, after the plasma cell rate is always above 80%, mostly 90% in the final smear, that we then move over to the fish part of our laboratory, but also we want to go into details of the molecular information. For NGS panels, as you see here, more and more we know now about mutations, variants in some genes, and we heard about on TP53, double hit, very important. There may be more genes as well. Some genes already have clinical importance because there are specific treatments for BRAF, as you know, from other cases of leukemias and also for malignant melanoma. So the first thing, if you want to compare anything for routine today, for clinical trials today and tomorrow, and for AI in the future, one needs to know what we speak about. And this CD138 positive selection really brings you to a pure plasma cell compartment. And if you only start with 15% of plasma cells, and as was said in the first talk before, the 17p deletion level should be above 20%, because someone wrote, and for sure this paper is wonderful, below 20% doesn't mean anything for clinical outcome. Was all these cases purified, or was it just the 19 or 21% in a normal smear of a bone marrow? This is really where the devil is in the detail. And then we need also to define about the IMWG response criteria, but I don't want to go into detail. Now, with respect to MRD, and thank you very much for the first talk, there are several techniques already where we can use MRD. With flow, we heard that, with PCR, and also with droplet digital PCR, more and more also with NGS, and also with mass spectrometry for the monoclonal protein fragments. But these techniques I see here in the front line of MRD in the future, and they all have pros and cons. They all need bone marrow normally, and they need good material. And we have up to 700 cases a day in the laboratory. And we look into all these cases, especially how many cells are in a syringe when it comes from a bone marrow aspirate. And we can sometimes tell you that we receive syringes or vials from University Hospital where we can see the number on the vial that was taken during the aspiration, and the number is 5 or 6 or 7. That means the first pool, number 1, 2, or 3, they are left in the university hospital for research or for routine diagnostics on a smear. But we have very few plasma cells at that time. So purification is very important if you want to reach a level of 10 to the minus 5 for MRD. That was a very, very good level. We know this also from CML and BCR-ABL1. But it's not so easy because you know that, especially in remission, and we all like those patients to be in remission, it's quite difficult to see some of the plasma cells. So where can AI help us in this situation in the future? We don't go into details, Aziz, you know this already, and you told this already about the machine learning and the deep learnings. But are there already some trials and there are some studies that demonstrate what could be done and helpful for patients' care? I don't speak for academia. I don't speak for pharma companies and new drugs. That's all important. I'm always coming from the view of the patients because we heard at the first talk, those patients will relapse at some day. Some patients from my have not relapsed after 20 years of the transplant, but to speak about cure is quite difficult still in these days of all these different treatments that are very successful, including CAR T cells. But can we pick up them earlier? If so, what would we do with them? At least follow up them in more detail. Could we get some help because we have so many data, pathology, clinical chemistry data, bone marrow cell count, we have all this X-ray stuff. What can one doctor calculate in his brain to be absolutely sure that he really understands what's going on in this patient and what will be the best advice to this patient? Because some patients, as you know, have watch and wait at diagnosis, many of them, because we have MGUS and all of that. So what will be the best, not the too late, but not the too early time point to treat those patients? Then going better with MRD, there will be also quite helpful tools with AI. I'm quite sure in the future, what would be very helpful is to predict treatment response and also who will likely achieve MRD from those patients where we start with the respective treatment. And for sure, as we have more than one drug in these days, optimization of therapy selection. Now, let's start with a little excursus to the plasma cells. So this is a quite clear case. I think everyone will agree that this is a multiple myeloma. But we use now in more than 4 years completely automated peripheral blood and now moving over to bone marrow smears for differential counts because, as I said before, it's a very subjective experience, observer-related method to call a cell a specific cell. So we use these automatic microscopes that go completely automated here to pick up the cells, and then we train these systems for peripheral blood and now for bone marrow to get the differential. This is for many reasons very helpful, not only for counting plasma cells, and we did a very, very extensive big trial running over 1.5 years on peripheral blood first, and we counted and named nearly 3 million cells of the differential blood counts, and 5 times as much we took pictures and named them by AI. And what we finally agreed here, human on one side, the differential on the AI tool on the other side, that this is not always the same, but especially for those malignant or critical cells like blasts, plasma cells, hairy cells, anything like that, we achieve a concordance between us as humans and the AI tool in 94%. And I will show you that this is a margin that's a number that's quite often achievable if you train with very experienced personnel on one side, because we are now the only ones, and we will be the last generation that will be able to control the AI. After that, there will be a time where no one will have the feasibility and the knowledge to correct such AI results. And how do we do that? We just take these pictures here right now from the peripheral blood, and they are completely digital. And when these pictures have been done, we look into them. We look into them with different magnifications or digital at our desk at our computer, and then we receive some of these circles. And this is the case with the primary myelofibrosis. And you see here, for example, on the side, there is a blast cell. But we can control this. We can control how many white blood cells was told there are. What about the platelet count? Do we see any other things? Because we never are able to allow the AI to make the final doctor's decision, so we can control the AI. And then AI tools can offer you, and you may know this from CellaVision, and we have our own tools in parallel to CellaVision's, offer you a gallery of cells and say, these are all the polymorpho segmented neutrophils, and these are the basophils, and these are the blast cells in this case, and we also see some normal blasts, and then it gives you the differential count. And if you don't like a cell in a specific box, you just drag and drop it into another box. And I can tell you that you should not have this done by unexperienced personnel, because then the AI classifier is getting worse and worse by day. So this is also now from the CellaVision. We have the same here, and we have achieved an accuracy of 93%. That means we have 25 classes of the peripheral blood, from up to down the human differential, from left to right the AI differential. This training set with many cells, nearly 80,000 cells, achieved an accuracy of 94%. Now in daily routine, hundreds of smears, thousands of cells. You see here more than 7.3 million cells already at that time point of the calculation. We achieve an accuracy in routine use of 88%. That means 10% of the cells we have to relocate, but next day it will be even better. With respect to the plasma cells and the CD138 positive selection. As I said before, we see more than 6,500 a year. That means between 15 and 50 per day. And we use such magnet activating cell sorting machines. And this is after magnet activating cell sorting, and then the cytospin that goes for FISH, or if there are more cells left over, the rest of the cells, and this is the case in 80% of all our cases, go for any kind of optional molecular investigation. That can even mean, and I will come to this at the end of my talk, that can even mean whole genome sequencing or whole transcriptome sequencing. But you see here the purification works very nicely, because you can see in this very easy staining after the purification that there are nearly all plasma cells. Then we go for FISH, and then we know what we count. And that means, and it is depending on the respective FISH probe, we can go down to positivity up to 3-4% positive cells, and the rest are negative, because we know how many plasma cells we have in the material. I do not say that 2% of something means that this is a bad prognosis, but we know from CLL, for example, that even 2 or 3% of TP53 deleted cells in interface FISH mean something worse for those patients. And we also now use an AI tool to count these signals, and not only by personnel, but here by an AI tool, and we reach by using this for different. This was the 5Q FISH probe. We achieve an accuracy up to 93%, counting these cells correctly. With respect to flow, first of all, define flow as it is used. You heard about already CD56 and CD19 and many other markers that are different between normal plasma cells and multiple myeloma. And that leads to such scatter diagrams you all know in daily routine, where you can pick up the plasma cells and the respective light chain restriction. But we can also use this for MRD. And we heard that there are some assays that are validated from Euroflow. Others use their own assays. And for sure, this is really a very important thing. Any clinical trial, at least, needs to set very strict rules. What does it mean to say this patient is MRD negative? What technique was used? What machines? What antibodies? This is true for FISH. This is true for NGS. This is true also for flow. Because if you can't compare it, it's quite different. I can tell you that we are part of many interlaboratory testings, and sometimes you're very surprised what's going on in the other laboratories and also in our laboratory, we all learn, especially in those techniques that really need a very, very high sensitivity. And we saw that achieving MRD here, status with 10 to the minus 5 is very important for those patients. Here is 4 years, 5 years, and it's quite a huge difference for those who achieved such MRD level. So how do we use flow now, including AI? So we know that we have this measuring of the machine, then we have compensation in the machine, then we have gating by the machine or by personnel, and then we have the personnel who reads these scatter diagrams. We use a different approach with the AI approach we use, not only for diagnosis, but also for MRD. I show you how that looks like. So when we go back to the morphology, we saw that we see the cells. Here, the AI tool starts with the raw data of the flow machine. So it does not start with the gating results. It does not start with the compensation of any software inside the Beckman-Coulter or BD machine. It starts from the raw data. And then it goes over and says, well, okay, these blue dots are normal cells and these red dots are the pathogenic cells. And you want to control the raw data information, and that makes the AI produce this picture on the right side, because we always want to see what's going on. Here, just the example, and this is the most important question we have in the lab from peripheral blood and from bone marrow and flow. Is there a lymphoma or is there no lymphoma? And this is a training and a test set. You see this over here, and the accuracy to just say yes or no. Here's the AI and here's the human. It achieves an accuracy of 98%. And if I tell you that in 75% of all cases with this question, lymphoma, yes or no, the answer is no lymphoma in the material we investigated, it's very helpful to get this AI before you start thinking about it. And then in the critical cases, you can go into detail. And there are critical cases. For example, lymphoplasmacytic lymphoma, much more critical than hairy cell leukemia, 96%. No evidence of any lymphoma, 95%. CLL, not so easy sometimes because it can be misdiagnosed with mantle cell lymphoma as well. But all over here, in all these different entities of lymphomas, we achieved in daily routine an accuracy of 87%. And in the CLL only classifier, we right now achieve an accuracy of 99% that this is a CLL, what the AI comes up as a CLL. And we can use this for MRD as well. So this is a multiple myeloma case, and the AI, for us to control, calculated back to these pictures, but the AI comes to the information and the result. We detect in 0.8% malignant cells running the myeloma panel. Here are 235 myeloma cells, and the rest are other cells. And therefore, our confidence is 98.15%. So that's the inclusion of flow, MRD, and AI before we start writing the report. And not for multiple myeloma, but for many, many other questions, we need still in all the staging systems and prognostication systems, the chromosomes. And this is a case, and this is a real-time movie where you start with the metaphase. And this is done by one of our very, very experienced technicians. And this was before we included AI. And you started with the metaphase, then you saw, oh, wow, this software, all digital, no paper at all in our laboratory since 20 years. They cannot separate these two chromosomes as two chromosomes. Now, okay, now we split them here, and then we have the chromosomes just here according to their respective size. And then by knowledge, phenotypical knowledge, as peripheral blood and bone marrow reading, the technician kicks by mouse click the respective chromosomes in real time to the respective position in the metaphase. And as you know, you need 20 metaphases for chromosome bending analysis to write a report according to ISCN rules. And you see, no one of us can do this so quickly, but she is really very experienced. And I can tell you, while I was speaking all the time, she needed here 48 seconds to make one metaphase to one karyogram. And this patient, it's a man, XY, and it has a trisomy 8 here. Now we have the same metaphase, and I will tell you when the AI starts and when the technician jumps in. This is the start of the AI. So no one is doing anything, but the AI is doing it. And this is also done by the AI, and this especially is done by the AI. And then here, the technician jumps in to control this result if it is correct. And this tool now is always before any personnel looks into something. And this is a demonstration with 20 metaphases, and the standard speed from metaphase to karyogram before the control of human starts. And that leads to 8,000 metaphases per hour, the completely automated picture taking from the metaphases, the completely driven, AI-driven tool to put them into karyograms. And when you come back next morning to work, you can start to control the results of these karyograms given by AI. We do not stop here. We now use, and Aziz, you said that already before, large language models to write the reports. How did we do that? We looked into 400,000 cases out of our 1.4 million cases we investigated over the last 20 years for historical data, and all the different methods we applied with all their respective results, because we have all in digital, and all the finally written reports. And then we have this new case from today, and there may be a question, anemia, multiple myeloma, whatever there may be. Then we have, according to guidelines, a mixture of the respective methods that are necessary or available. And then we use similar cases from the historical cases, apply some rules, and let the report written. Before we control the written report, we use a second AI tool, the so-called judge model. And this tool asks for, is it everything correctly written, grammatically correct? I can tell you it's much better than humans writing. Then is anything mentioned that wasn't there, or more than that, hallucination, any irrelevant stuff. And after that, you receive it for your control. What you can see here in the last 12 months is the red ones are first created by the large language model, then controlled by our personnel, and the dark ones were the other way around. And you see we are now nearly 85% where first the large language model and then the human controls. Now we take back the case of the PMF before, you know this case, and there you can see, and it starts here, how this large language model works. You see the differential count, AI plus human control over here, it's peripheral blood, and here the large language model starts. Looking into the historical controls, you see the seconds going up, and after 6.8 seconds, there is the report, and this is the report. And then you can just change the words in the report you don't like. The system learns from that, but I can tell you that in 85% we do not change any word because it's fine, but we control them anyhow. Now we learned about all these treatments, and I would like to give one more thing, including AI, because there are so many treatments now with targeted molecules, and you know this is quite expensive. All these immunotherapies, all the CAR T cells, and we really achieve a lot of permanent, long-term remissions for these patients. But in these guidelines, for example, from UpToDate here for newly diagnosed or for relapsed multiple myeloma, you do not see any MRD, and you especially do not see any AI. Well, that's not a surprise, but you see so many wonderful and especially very expensive drugs and treatment options. And we can now see here that there are, in the last years, some papers have been published that demonstrate, for example, this score here, a model that predicts the progression-free survival and the overall survival in newly diagnosed and in relapsed patients better than all other tools that we learned before from Dr. El-Ahmadi's talk, as well as what I showed you at the beginning. We have a higher concordance index than most standard models, and especially we can see a risk for serious adverse events also by using such AI tool. And this is the difference here, or two different treatment protocols as published before. And this, if you use AI, demonstrates a better, more broad difference in outcome here in patient subgroup by this AI-driven tool. And this can also pick up some very specific subgroups in patients that we didn't see before when we use our standard approaching tools. And what is even also very important is that you can go with AI to routine blood work, and you can demonstrate better here the relapse probability for those patients going into progression in comparison to those patients by such AI tools. A recently published paper, 2025. Last thing I want to address is how can we use, or we see this in our research right now, very, very successful genomes and transcriptomes. And this is a patient you see here, and we demonstrated for this patient after BCMA targeting CAR T cell therapy that this patient has an homozygous 16p deletion, including the BCMA gene. And that means there will not be any further effect when you do such a treatment. And that means, especially when you think about second CAR T cell therapy, we think such methods like genome sequencing and also transcriptome sequencing may be very helpful. It's feasible. You can do it on separated plasma cells, and it's quite cheaper than using such treatments again. So what I would like to end up here with two conclusion slides is, first of all, there are many things to be addressed in the future, and I think it would be a shame to address all this risk stratification and all the very, very successful drugs with multiparametric scores without AI. We may need FISH for sure. We may also need molecular mutations, and we may even need gene expression profiling by genomes and transcriptomes in the diagnostic workup, especially in a second or third remission situation. And not only in trials, but also in daily routine MRD methods that really are validated should be applied in those patients. Right now, we see flow at the beginning for sure, and it works. We also see NGS in the next future, but we don't see many more techniques as in MRD right now. And with respect to use of AI in the laboratory setting, we start with the doctor and the patient. We see what paperwork comes from the practice to be scanned by us, and start then with an order control hematologist that says for these questions, and also talking back to the doctor if he's really sure we need a composition of such options of techniques. Then we do all the lab, we do all the personnel, and then we write the reports. But by writing the reports in the large language model before, we also include information from clinical trials, from WHO, and from any scoring system. And then we send out this to the respective doctors. And we can support all this by AI. And I think it would be a shame not to work on this very, very hard to implement this by our human control as soon as possible, because we need to serve patients best, and AI is there, it will never go away. I would like to thank you for your attention, and I would like to thank my laboratory for all this hard work they do in routine, they do in research, and they do in testing AI, and they are not afraid that they lose their jobs. They are very happy that they are supported by AI. Thank you very much for your attention.
Thank you very much, Torsten. That was amazing talk, and really showed how true AI can be applied in real life setting in the diagnostic labs. So that was amazing. So thank you very much. So what we would like to do now is to open the conversation, obviously, with the speakers. And please, if you have any questions or comments, just put it in the chat sections, and we can start have the conversations. Would love to hear from you and make this more interactive. Obviously, I'll start with some questions. I have a lot, but we can start here. So I'll start with Dr. Maged. You put like very, very amazing picture about the prognostications in myeloma. And we have so many models now, and I see it, part of the research that I have done before is looking at prognosis in myelodysplastic syndromes. And what we found, what the models tell us, and what the actual patient survival is completely different. So the model could label the patient high risk, and patients sometimes behave lower risk. You put out a very interesting case where standard case, lower risk, and now all of a sudden this patient is really sick and high risk, which probably maybe the disease trajectory wasn't studied that way. So how do you see that now improving or moving? Are we better recognizing those patients, or we still have way to go in multiple myeloma to recognize those patients early?
Okay, so thanks for the question. Yeah, so are we improving or not? So the answer definitely yes, because I showed you the progression in the simple ISS scoring system from 2005 ISS, then 2015, after 10 years, the RISS, so incorporated the LDH and cytogenetics, and then now the R2 ISS, which gives a value for each point. So 17P will give the patient one score, 1Q will give 0.5. So it's not putting the score equal among variables, which that's very important point, because the significance of 17P is not equal to 1Q, not equal to monoallelic 1P. So that's one thing. So we have to not deal with all the variable in the same way. Same thing also the beta-2 microglobulin. When I was in medical school, for example, we learned that any beta-2 microglobulin would be high. Now we know that it's correlated more with the normal kidney function, because if the patient has a abnormal kidney function, that by itself will increase the beta-2 microglobulin. So now we are understanding the concept behind that in a better way. But are we done? So the answer definitely is no. And the case that I showed you is not the only case. I'm sure everyone treating myeloma would have lots of similar cases. And I think that's related to the, it's a multiple clonal disease. So we have one dominant clone, but under that there are other subclones that has high risk features. We might not be able to detect it, and then with the treatment, that subclone might be the dominant one and becomes the way for the relapse. And unfortunately, at the time of diagnosis, because that subclone is too small, we might not be able to pick it up. We will pick the dominant one, and the subclone, we don't know about it. So that would be one concept of why there will be a difference between the score we will get for the patient at the time of diagnosis and how is the clinical behavior. Also, the molecular studies, I think the similar concept identified on leukemia, for example, the whole exome sequencing or the whole genome sequencing will give us more details about other mutations that's not incorporated in the prognostic algorithm, but that doesn't mean it has no role. Maybe we don't know. Maybe we don't know what's the exact prognosis, or how we can change or modify the treatment based on these mutations. One important point was mentioned by Prof. Trosten in the beginning, which is drawing a line, which is really, it doesn't make sense. Having a categorical variable, it doesn't make sense. It should be continuous. So someone with 17P of 18, should I call that 18% of the cells are negative, or 19% of the cells are 17P? Should I say that? Should I say this is not a high risk? And someone who is 21 would be a high risk. So I think the module should go, and that's what's happening in other diseases. For example, now Hodgkin lymphoma. So the EHIB score, they moved everything to categorical values. So, if the mass is 4 centimeter, would have a better prognosis than 8 centimeter, but 17 centimeter will be in the middle. So you should not just draw a line. Okay, I have this. If you are above it, you are bad. If you are below it, you're good. So that's an important concept also we have to understand.
Beautiful. Awesome. Thanks, Majid. Torsten, please, if you have any questions, please put it in the chat and then we can bring it to our panelists. So Torsten, you put an amazing use case where, you're using AI, but you still have your team and you're trying to automate the tasks, which enable you probably to process samples faster between human plus AI instead of, AI is robots rolling off the labs and humans are sitting in their home. And I think that's an amazing way to kind of collaborate with AI. And I was recently at the NIH, and the speaker before me was talking about this collaboration between AI and human and the consequences of that collaboration. And what I would love to ask you is, how do you look at this? So what we've seen in some research, AI plus a human, you have an options of over-reliance on AI or under-reliance on AI. And over-reliance on AI has its issue, or under-reliance on AI has its own issue. So for example, you saw where the AI is sort of doing the side of genetics and the human check it. Now, if a human did not check it or say, the AI is doing great and then move on, how do you address that?
So from the bureaucracy rules, any report, any result is a human report, first of all. So if I would promote and would say in this talk or in my daily life that we do 80% of the diagnosis without any human control, I would be killed in the German healthcare system. That's okay. I completely agree with that. And if you go to standard routine laboratory stuff like measuring an LDH or better to microglobulin, no one will ask you if you control this 5,000 LDH results per day by humans. You just do a specific quality control at the beginning of the day, and then you believe everything is measured correctly. Right now, we are not there in hematology diagnostic because it's too difficult. But I can tell you that there are many, many things that are stupid for humans that are intelligent people. And they may like to pipette one thing 5,000 times a day, but this humans are not so common. And even if they are, they make a lot of mistakes from 0 to 5,000 times a day. And therefore, we don't discuss if an automation pipetting robot is acceptable replacing humans. And the same is true for many, many other things where we right now use humans to do it, because my personnel is very, very keen and very tough to do interesting things. And therefore, I can tell you that there is no drawback by implementing to their side the colleague AI. And this will stay for maybe at least 5 years, and then that will change. If you go for your autopilot in your car, you believe when you say, drive me from this place to this street and this number of the house, and you do not have a map on the other side in your car and look into the map still. That was 20 years ago. So the times are changing, and this is also true for very specific diagnostics in leukemia. And this personnel is so highly educated. They know all the WHO classification. They know all these things. This is not clinical chemistry. There are many things to know as well. But now there will be the next WHO classification. You cannot learn this by heart. You need tools, AI tools that help you to be state of the art. And therefore, I'm quite open to implement this even more in the future. Hopefully, then I can replace myself and can retire.
If I may jump here real quick, Aziz, I
Yeah,
think one
please.
of the things that always, yani for me, I see it, AI will play a major role in the future, although the way I see this is going to be implemented is difficult to understand. And I'm afraid that as Torsten said, that in the future, currently at least we are still controlling the AI, but someday this control may be lost, and then we end up not understanding how the AI actually gave whatever recommendation or task it was supposed to do. So one of the things that always fascinates me in medicine in general, and myeloma, we can take this as an example. When we talk about prognostication, all the previous prognostication models are static in nature. So they are static at baseline, and they depend on mostly on data of patients, number one, not treated, and number two, are treated with standardized therapy. Then you are left with this huge gap of dynamic forecasting. So dynamic forecasting, which take into account, detailed therapeutic data, response data, and as well as toxicities and patient-reported outcomes. So my question to Prof. Torsten, are you in your models right now, are you integrating any therapeutic data or no, it's only diagnostic in nature? And if you are, how are you doing it, and what kind of data are you feeding in the
Yes,
models?
a very important question. So right now we use our models only for this moment when the patient sample arrives. It may be at diagnosis, it may be for MRD and follow-up, it may be at relapsed question mark. Because we need to write these reports, we, as Aziz just said, we save time. For example, by implementing AI for chromosome banding analysis, we went from 7 to 5 days for turnaround time for a chromosome banding result. That was 2 days less than before. It really makes a difference. But with respect to the prognostic information, we so far do not use this because we have not problems, but we miss this therapeutic information and this outcome information and all these results from the creatinine that you know from the hospital, because in Germany we don't have electronic health records so far. Crazy story. And we cannot get the data. What we do is that we follow around 70,000 of our patients in master cohorts. We have 5,000 patients of the AML master cohort. We have 5,000 patients in the MDS master cohort, and so on and so on. And for those patients, we ask our doctors to send us the status of the treatment and the outcome once a year. And the feedback rate is 93%. And that automatically goes into our database, and therefore in the future we will be more and more able to do what you just suggested, not only look into what we already know because we did this diagnostic approaches, but also what does it mean for this respective patients that we diagnose and their treatment and their clinical outcome. This is not a clinical trial, it's a real world scenario, because nearly all of our patients are not in any clinical trials. They are real world scenario patients. And I will never stop controlling the AI right now. We need to control that because we also see stupid stuff. But as I said, and you said as well, so far we can control it. And then we go back and do it better next day.
Can I ask a question, please?
Yeah.
So for Dr. Torsten, so now the circulating DNA in myeloma has some clinical importance in terms of prognosis, in terms of follow-up, MRD assessment, and all of that. What's the role of AI in that particular matter? Especially, it's I would say it might be an easier to pull up data and then build a module to help in stratification in the way of management and all of that.
Right. A very good question. So I can tell you from the laboratory point of view, it's not so easy with the cell-free DNA measurement, and but you are quite easy to get the sample because it's just peripheral blood. So that's for sure. And this is also true in multiple myeloma. What we build up right now is an assay using this approach for diffuse large B-cell lymphomas. And there are some assays on the market from companies. We don't like things like that. We don't want to buy any assay that we may also build up ourselves and validate it and accredited it, that we always do. There is no test in the laboratory that is not accredited according to CAP and to ISO 15189. And we will have the cell-free DNA assay for diffuse large B-cell lymphoma for this question in comparison to PET scan in the beginning of next year, and that we will offer this in our daily routine for this entity first. And then there may be multiple myeloma second, because we really think that this is a very good entity to use such assay as well. You are completely right. I like this a lot, this idea.
Awesome. Any questions from the audience? We still have probably 4 minutes. I can ask sort of more like Dr. Philosophical questions, Thorsten, and maybe for Majid too, because also this came up in this recent conversation at the NIH. So as we integrate AI into clinical or the clinic, and as you integrated it into your lab, one of the worry, and that's not my worry because I can tell you my opinion is the opposite, but one of the worry is that are we de-skilling doctors because now they are relying more on AI? So for example, you mentioned in your lab, you have this very experienced cytogenetic experts looking at those cytogenetic experts. If you're gonna, let's say you embedded AI in your lab now, you're bringing a new person to that job. But now that person gonna learn that AI gonna do this, and I'm gonna just check that. Are you worried that the new generation will be de-skilled compared to the old generation that learns everything from scratch?
Aziz, I have to handle 385 people in my personnel, and 75% are women, and they are sometimes pregnant, and nearly everyone wants to be in home office. That's quite difficult if you handle the sample and the PCR machine. They want to be in vacation, and they want to work less than 40 hours a week. So don't tell me that I do not need machines and any tool that helps me to deliver the result to the patient. I care for patients. Second, I care for my personnel. And I'm not afraid that those people are not interested anymore, because it's much more interesting and to have a purpose when you do a job where a leukemia patient is behind the probe, the sample. And therefore, I can still find personnel that really wants to have a job where there is a purpose, including all this work-life balance that was not known when I was in that age. But I'm not afraid, and the other way around, I would think if we don't do it now, we would really, and someday we'll be in a situation where we don't serve our patients best. Just the last 2 numbers from my side. When we started 20 years ago, we had on our molecular list for requests 40 genes. Now we have 300 genes you can ask to be measured in daily routine. Who should know all that, including their clinical information, their prognostic information? And if, Dr. Mahed, you also said that if you have 1 or 2 or 3 or 4 of these genes, who should know that? No one can know this. We need such help if we want to be good doctors and teachers as well.
Love it. That was my answer, but but the old guys in the meeting was like, no, we should do,
They are old. They will retire.
We should go to the cadavra and play with the cadavra because this is how we train in medicine 50 years ago. But this
So I
is
will ask you, Dr. Aziz, now, which one will trust more, a human or an AI for yourself?
yes.
And I'm sure this is you started with some philosophical question, and lots of people will be scared of having just a machine deciding about their diagnosis.
I would trust a human who uses AI the most.
Yeah, that's it.
So it's interesting. I know we are up on time, and this is very important question because trust from physicians is different than patients, by the way, because there are new studies showing that patients have less trust in physicians who use AI compared to physicians who don't use AI. So there's a lot of educational stuff there. The trust part honestly comes with time. And this is like, I know there are not that many Teslas in Saudi Arabia, but the first time you go on Tesla and put it on autopilot and you go on a highway, you will be freaking out. I can tell you that because that's what happened to me. That's what happened to my wife.
And to me as well.
She will not ride the Tesla anymore, right? But over time, what I realized that the Tesla actually is doing better job than me. Now, I feel like I can cook in the car. I pay my bills in the car. I do all of this stuff in the car. No problem, right? So trust is a matter. It takes time. And it's going to take time, especially with technology. And that's something you build. It's like a human, you don't trust the first person you see. Trust needs time to build. As we use those models in the clinic, as we get familiar with them and learn how to use them, I think that trust will increase. But at the same time, we need to address this issue now with over-reliance on AI, under-reliance on AI, because also under-reliance can be a problem, by the way. And the guy who mentioned that in Chernobyl, for example, what happened when the bomb went off is that the machine gave them alerts, but a human ignored it because it's like, this is not, it's not. And then that's what happened in the system, and we got Chernobyl. So it's also, a lot of dynamics can happen between, am I trusting it too much? And now that's, I'm not even looking at the report, and now a bad report come out and it's a problem. Or am I just ignoring it? Like, okay, click, and then now another bad thing happens. So I hope in the next few years, we will be able to work more with it, trust it more, and then hopefully all those issues get resolved. We're at time now. This was wonderful. I love the session. Thanks, Majid, and thanks, Torsten, for the amazing talk.
Pleasure. It was really fun.
And Ahmed, do you have a few words at the end?
No, thank you. I think we are very honored today that we had two excellent speakers, Dr. Majid bringing his clinical expertise, and Prof. Torsten, huge lab. I think your lab is probably one of the biggest hematology labs in the world. So what we've heard here is cutting edge usage of AI and this approach in hematological malignancies in general, not only myeloma, but I think myeloma is unique because of the utter need of such prediction models. So thank you very much. Again, I would like to thank all the SSBMT staff, to thank again Johnson & Johnson Janssen for their sponsorship tonight. And my co-host Aziz, thank you always, and hope to see you next month with our coming lecture in the series. It will be regarding stem cell transplant approaches. So see you then, and have a great evening, night, afternoon, everybody.
Thank you so much.
Thank you very much.
Thank
Thank you
you.
for having me.
Thank you.
Bye-bye.
Thank you. Bye-bye. Bye. Bye.